Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by the award-winning quarterly journal AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Meagan Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to today's episode of Voices in Nursing. I am Brandy Pack, the Nurse Content Strategist here at AACN, and I'm joined by my colleague, AACN Practice Excellence Supervisor, Sarah Grishow.
Hi, everyone. Thanks so much for having us.
Cannabis is one of the oldest cultivated plants with uses stretching back thousands of years, from fabric and medicine to ritual and recreation. Fast forward to today, cannabis use is legal in many states, while available in different forms and even under federal review for reclassification from a Schedule I to a Schedule III drug. But what does this mean for us nurses at the bedside? How safe is this cannabis use, and what should we be watching for with our patients, especially in the critical care setting, where drug interactions and organ dysfunction is very prevalent? Joining us today to break it all down is Dr. Meagan Good, PharmD, who has studied the impact of cannabis use, including in some of our most vulnerable populations like transplant patients. Dr. Good, welcome. We are excited to learn from you.
Hi, I'm excited to be here today.
So, Dr. Good, just to get us started, could you share a little bit about your background and how did you become interested in studying cannabis, especially the use in healthcare?
Yeah, so I have a pharmacy degree, so I began my medical field pathway very early on in high school. Ended up deciding to go pharmacy, finished my 7-year degree, and last year I got the opportunity to complete my PGY1 pharmacy residency, which allows me to further my education. During last year, I had the opportunity to do a big presentation over cannabis, and so I just dug into the literature and really enjoyed it. But during that time, I also looked into going into pain as well as palliative for a career pathway, and I'm completing that portion of my training now. But what I really learned throughout that was like there is an opportunity for cannabis, but it comes with a lot of risks. But with the legalization coming across the United States, there's a lot of more cannabis being used, but we don't really know necessarily how it works, or more importantly, from my perspective, how it interacts with all these different medications that we know have great efficacy. And so now it's my little side project and just enjoy reading articles and seeing how it can potentially affect our patients.
That's really cool.
Now we hear the word cannabis and all of us picture maybe just a few different things. You know, we have THC, CBD, marijuana, hemp, the good stuff, the grass, you get the picture. But can you help clear it up? Like, what exactly is cannabis and how do these pieces all fit together?
Yeah. So the biggest thing with cannabis is that you have marijuana and hemp. And so those are derived from what majority is derived from the cannabis sativa species of plant. There's multiple different species that it can come from, but the main one being that cannabis sativa. And so it can be separated between the hemp portion and the marijuana portion. The marijuana is what's regulated more by FDA and general guidelines, but the hemp is actually more regulated by our agricultural side of regulation. And so it's not very much talked about as much because it's such low levels of THC and CBD. I think the biggest point that really matters is the THC versus the CBD. So it's THC, tetrahydrocannabidiol, and then you have CBD, which is cannabidiol. And so those two components are what make up our marijuana. And so with the marijuana, those two factors are what will give the effects for our patient. And so looking at our THC component, that's our more psychoactive component for our patients, whereas our cannabidiol is less psychoactive, doesn't have as much of that. And so that's where patients will be either using the CBD versus the THC, and you'll see the concentrations on many products and how patients may pick what product they're choosing to use at the time.
Thank you for sharing so much information. There's so much cannabis use on the rise that I kind of want to talk numbers. What do the latest statistics tell us about who's using it and how?
Yeah. So some of the statistics back in 2020, we only saw about 50 million people in general using marijuana. Back in now in 2023, we're seeing it closer to 62 million patients. So we've seen about a 10 million increase in marijuana users. But I also like to talk about marijuana use disorder when I think about this because just like opioid use disorder or substance use disorder, it's a real thing. And back in 2018, it was really as low as 1.6%. And when you think about how large of a population we have, the numbers weren't that high. But now in 2023, it's up to almost 7%. And so seeing those numbers on the rise just shows you how much more we're seeing it in our communities and potentially seeing it in our patient population as they're walking through our door.
Which is really
Yeah.
interesting because I
It's
actually
like,
don't meet the criteria, but I had my marijuana card for a number of time before it became legal in Ohio. So it's really interesting to hear those numbers. Brandy, what do you think?
well, I'm based out of California, so we've been legal here for a hot minute. So, but I am interested though, like from your perspective, what's a common reason people are using it, or at least telling us why they're using it?
Give me just one moment. I have a nice list over here.
Well, I can tell you the reason I was using it was with a cancer diagnosis and trying to ward off any potential nausea. Luckily, I never got to that point, but I was able to qualify for the card in case I needed it, which was actually really nice.
Yeah, like Sarah just said, is with nausea is one of the big ones. And, once we go through this list, I also think something we can talk about is actually how marijuana has a great risk of development of nausea as well. So we could hit on that as well a little bit. But some of the main reasons that we're seeing our patients using marijuana right now is anxiety. It can really help calm patients and just bring that feeling of just calmness. Glaucoma treatment, there's been newer data showing that it could potentially help with treating glaucoma. And when you think about it from an eye drop perspective, those are very annoying when you could just take a little gummy or something that's much easier. Nausea, like we just said, AIDS-associated anorexia and wasting syndrome. One of the side effects that can sometimes be used as a beneficial factor is that these patients are having increased appetite. And so if they have, for some reason, a lower, so like they have anorexia, they're increasing their appetite and helping with that. Chronic pain, which is kind of one of the reasons that I've kind of found that my little niche in this, inflammation, and then we also see it with epilepsy as a way to treat epilepsy as well. And so these are some of those reasons, and it's really for most patients, they find it very beneficial.
Now, for those patients, I mean, in my previous life here as a leader in a same-day surgery in a post-op unit, we often struggle with patients being really forthcoming about their recreational drug use. Do you have any advice on how these nurses at the bedside can approach that conversation in that way that really just builds trust?
Yeah. So that's like one of the biggest things that I found when I was doing a lot of my research with transplant is that a lot of patients don't want to say that they're using it because they may not be listed for transplant. They may not be eligible for other medications that could help them by saying that they use marijuana. So I think one of the biggest things from my perspective is destigmatizing it. And but also really educating our patients that we don't necessarily want to tell you this is like we're not going to take it from you, but we really need to know for better dosing other medications that you may be on. One of the biggest things with marijuana is that it has many drug interactions that either could put you at an increased risk or potentially you won't see as an effective use of the medication that we're using. So when I think about a bedside nurse and how they could approach a patient, they're the ones there all the time. You're able to develop the rapport much more than me as a pharmacist stepping in, but really just telling them like we just want to let them know so that we can dose your medications appropriately, so that we can adjust it there and take it from that actual side of like the side where it's not statistically, but take it from a point where you are using the data to back it up and why you're asking, but rather using it to be a negative thing in the bedside.
That you make such a great point with that because I think that's one of the things that when I was a bedside nurse, I would try to impress upon my patients most was I don't care that you're using it. Just let me know so I can better help you because your pain receptors are going to be much more or much less sensitive to what I could potentially giving you because of your use. And so when we think about that, and you were mentioning glaucoma and AIDS-induced anorexia and anxiety and epilepsy, um, that's touching on multiple body systems. So could you give us like a broad picture of how it impacts the body overall?
Can I give you a broad picture? Broad picture is it affects the body everywhere and in some way.
Check
Um,
everywhere. Got it.
But I think the biggest distinction with that, though, is that the marijuana is affecting the CB1 and CB2, that endogenous cannabinoid system. And that endogenous cannabinoid system is all over our body. And so by saturating these receptors, so with more use, you have more saturation of those receptors, we're seeing that all these different parts of the body are affected. So the brain, the lungs, your cardiovascular system, your intestines, even the immune system. So our patients who might be immunocompromised, or even our patients who are on temporary antibiotics are being affected because their immune system is being having to work by having those cannabinoid receptors saturated. And so it affects all sorts of portions of our body. I mean, reproductive system, your muscles, even within the bones, we see those CB1 and CB2 receptors. So it's all over the body that this endogenous cannabinoid system exists. And so that's where we see the broad effects of the cannabis or the marijuana.
I think this is just fascinating to me.
Me
This
too.
I just boggles my mind. But when it comes to like how people are doing it, I did see in some of your research of like how they're getting it into their body. And I just feel like if you can touch on a little bit of like what the difference is and like, what I know some concentrations are different and things like that. But what are the forms that these patients are kind of using?
I mean, when you think about it, right, most people are thinking marijuana as inhaled on the street, right? Or you're thinking about like the gummy formulation. And so the things to think about like with that is like with inhalation, we do see more of a risk in the lungs, but that actually can affect the whole body because it's affecting all those CB1 and CB2 receptors. But in addition to that, with the gummies, we're doing it orally, but then there's sublingual oils where patients are either using it under the tongue or they're directly swallowing that oil. But then in addition to that, and something that I kind of even learned during my research is that we're seeing it used topically as like a cream to kind of help with different joint pains or temporary like muscle pains, as well as rectally. And so, like a lot of our other medications, where you think about the onsets of action and things like that, which you all as nurses are very familiar with, by doing it rectally, it's going to be a lot quicker. You're going to see that quicker onset, but but whereas with inhalation, we'll see it a little bit faster than rectally, and orally being our slowest way for these patients to absorb it. And so I think as you're a bedside nurse who may be taking somebody as a trauma patient up to the floor and you're reading in their note, like they've inhaled it recently prior to admission, or they were seen with gummies next to them prior to admission, you're really able to think about, well, are they at their peak effects of their cannabis right now? Is it potentially slowly leaving their body to kind of help you think about the side effects, but also thinking about their receptor saturation. And if they are going to be peak, are they going to be going into like a withdrawal situation? And we need to think about that versus do we need to just treat them as a normal patient?
That's really interesting because I also then wonder about these THC and CBD drinks that are hitting the market, and you see them marketed like together, and it's like 10 milligrams, or it's THC 5, or it's CBD 5, so how, when we are thinking about being at the bedside, so taking this
Mhm.
back to nurses, we're always the first ones to notice side effects. We're always to notice when our patients are changing. What should we be watching for when we are taking into account gummies, drinks? The lotions aren't really impacting someone as much. And the doctor that I actually worked with when I was getting my card, he actually encouraged me to use those different methods because he's like, let's not trade one cancer for another. which I found pretty funny coming from a doctor. So, um, but what can we watch? Because I'm sure those present very differently.
Yeah, so when you think about like cannabis side effects and things like that, like I said, with the lung inhalation, those patients are going to be much more at risk of like the cough and decrease in their O2. We may see them desatting more often, or they may have a bit more of an O2 requirement bedside. I know for me as a pharmacist, when I see new O2 requirement in the chart, I'm like, what's changed overnight? Things like that. And so from the bedside nursing side, you're able to see that acutely, see if they respond to that, but then also kind of knowing their history or being able to tease that out, you're going to notice that a little bit more. But I think the other thing to consider with these patients is drowsiness, fatigue. When they're at their peak of their cannabis, they're going to be very drowsy, fatigued. They may look very peaceful though, because that's why a lot of these patients may use it is so that they can have that relaxation that they need. The other thing is dizziness, and especially bedside nursing rounding and things like that, and trying to get our patients up and moving. Are they having dizziness that's not correlated necessarily to blood pressure changing, to a heart rate changing, to a different medication that's commonly associated with dizziness? That really could be a potential with the cannabis side of things and how their cannabis is affecting their body. But like we said, any change across their whole body that we can't correlate with necessarily an acute injury or why they're in the hospital because of where those CB1 and CB2 receptors are. And if they have that correlation with cannabis, we should really consider that as something to do with the cannabis.
Gosh, it's so interesting. And I feel like I feel like we could ask so many questions and talk about so many different pathways. It's so cool to see your passion shine through for what you have dubbed as a side project. And, Brandy, it makes me think about medications. And weren't you thinking, didn't you have a question around that?
Yeah, we were just wondering about like the FDA. Like what's the FDA doing out there? We know we've heard approved a few cannabis derived, products, but like what are they actually being used for? Or, like are they being using on label, off label? Like
Yeah.
what's going on out there on a standpoint from the FDA? How about that?
So from the FDA standpoint, we have two medications, one of which is a CBD-based medication, and then one which is a THC-based medication. And then you have, and if we're going to touch FDA, I got to kind of mention a little bit, you have like the medical marijuana side. And so a lot of the medical marijuana-based places, and especially between states, are regulated based on how much THC and CBD. And if it's being gotten from like an approved medical distributor, it's typically being tested to make sure it doesn't have necessarily any impurities in it. So it's a safe product, but it's being used on that medical marijuana side, but not in an FDA approved setting, technically. But on the FDA approved side, we have two medications, cannabidiol, CBD-based component. And for my experience, we use this a lot more in children, mostly because it's a liquid formulation. And so it's a CBD-based one, and its two FDA-approved indications are with seizures associated with Lennox-Gastaut syndrome, and then also with tuberous sclerosis complex associated seizures. So it's really
Wow.
associated with seizures and treatment of that. And then on the other side, we have our synthetic THC product, which is dronabinol. And so that one has two FDA approved indications of anorexia in patients with AIDS and then refractory chemotherapy induced nausea and vomiting. That one is currently an FDA Schedule 3 medication, whereas the cannabidiol has been no longer FDA scheduled medication. It's no longer considered a controlled substance within about the last 3-ish years. I will say dronabinol, from my experience, I have seen it used a little bit on a non-FDA approved basis in cancer patients, mostly because it can help with appetite. And so our patients who may not necessarily be eating as much, and that may be why they're hindering from leaving the hospital, or they're not being able to necessarily wean off of the TPN or wean off of their tube feeds. I've seen that medication used in that way. And that's really, when you think about it, it is FDA approved for anorexia. in patients with AIDS. And so it's using that same methodology in the cancer patient population to help with their appetite to prevent that potential anorexia kind of development and get our patients out the door.
So it has some potential. It's got potential good looks, potential bad, all of those kind of things putting it together. Now, I did see in your presentation that interaction with medications. I know we kind of touched on a little bit, but what are those some important medication interactions? So with those common ICU drugs that nurses really, should be paying attention to and, things
Yeah.
along those lines. Yeah.
I mean, ICU nurses know a lot about drugs, and sometimes I think they do know more than me. But one of the big things that I kind of want to point out in the big picture of drug interactions with the marijuana or cannabis use is actually the fact that it's a CYP3A4. And so with that, it affects our CYP3A4 substrates. And so it's an inhibitor of those medications who are metabolized by our CYP3A4 enzyme. And so with that, there's so many medications that can be affected. And some of them being simple things as apixaban, amlodipine, atorvastatin, bupropion, and buprenorphine, I apologize, and bupropion, carbamazepine, a lot of our benzodiazepines, which I feel like I see our benzodiazepines used quite a bit more in our ICU setting to maybe help with potential agitation or bedside procedures. But in reality, they're not going to necessarily work as well in a patient who is actively using cannabis because they're not going to be metabolized properly with cannabis in the body. Things like dexamethasone, which we'll see a lot in an ARDS situation in an ICU, will not be used as well and metabolized properly. Warfarin is one that I feel like I have to call out. It was one of my big little projects. And so with warfarin, we've seen multiple case studies where these patients are having a higher level of their INR, increasing their risk of bleed. And many of our nurses know what a normal INR is. They know 2 to 3, and all of a sudden seeing a 5-level INR will make a lot of them worry. They're going to page a doctor, as they should. And so just kind of knowing that those levels can be increased, or on the other side is that we may be treating a patient accordingly. Here's a patient case example. You take over a patient, right? They were outpatient on 10 milligrams of warfarin. They come inpatient. They're no longer using their marijuana daily. That 10 milligrams is going to be way too much for that patient. And so really you're going to see that INR just begin to spike up and change, and they're not going to be properly anticoagulated. And then they're going to decrease their warfarin dose down to like 2 milligrams a day. They're going to discharge. That patient no longer properly anticoagulated because
It's like a circle.
because they start using their marijuana again. And so little things like that where I feel like it's really important that we have to just destigmatize this. Because if
Oh,
we
for
know
sure.
that when they leave, they're planning on using again, we know that their warfarin's going to need to go back to their home dose.
Wow. Sarah, can you imagine being in the ICU and being like, your patient's more, it's this, and then all of a sudden it's not? Like, we wouldn't even think about cannabis. We'd be working them up for something way different. It's
For
like, I feel like
everything.
there'd be one nurse in there being like, hey, do you do a little cannabis on the side? And they're like, yes. It'd be like, boom, mind blowing. I
But
just
now
think
I feel like
nobody knows about it.
but I'm going to think about this now. I feel like every time I walk into a patient's room, especially, I'm going to be at the hospital on Friday, and I'm going to be with oncology patients. And so it might have to become part of my new questions.
Yeah, but
And
what
it's
wasn't you a big transplant that wasn't your kind of focus in transplant? Like what is all that doing not only to warfarin levels or to warfarin, but like what's it doing to your TAC levels, pro
Yeah, so
and
I
all
mean,
that?
we all know post, and especially a lot of our ICU pharmacists who are doing like post heart transplants. And I think about my time in the CT ICU, like we're messing with their tacrolimus levels and we're getting them to this perfect level. You've worked hard because you as a bedside nurse know, like, oh, level's wrong. I can't give my dose right now. I need to wait until we figure out the adjustments. And you finally get them on this level. They're doing great. you have become a part of their team as a nurse and you get to discharge them, only for them to come back a week later. Why? Because their tacro level is uncontrolled and nobody can figure out why. And that's because tacrolimus is so affected by cannabis use. And that's where I say that it's so important to destigmatize it, because if we know that you're going to use the tacro outpatient, and we know that you're consistently taking a 10 milligram gummy, for example, then we're going to be able to adjust your tacrolimus dose based on that. But your tacrolimus dose is affected. Even cyclosporin, even sirolimus, which are all commonly used ones, those levels are affected by our cannabis use. We've seen many case reports, we've seen multiple studies that have shown this. And so just to have the knowledge as a practitioner, it is great to develop that relationship. And like I think about you as a bedside nurse who have taken care of the patient for the last 4 weeks, and then all of a sudden they come back.
Like, welcome back, Mr. Smith, and we'll try again, you know?
We'll try again, but the thing is that if the patient doesn't have a rapport with you, the patient's not going to tell you that what they did outpatient was that they took cannabis to help them feel better because it's helping them sleep at night. And in reality, it's affecting their tacro levels.
So it's like if we could just get them to be transparent to begin with, you know, and then we could figure out how that affects it and then dose those levels appropriately and then send them home. And maybe Mr. Smith can stay at home. So we just need to build that rapport. I think that is so key here.
Yeah, and through my research and like what I've learned is like at this point, it's not going away. Marijuana is here to stay. And whether it's here to stay, whether you're in a state that's approved it completely, or you're in a state where it's only at a medical side, or you're in a state that hasn't completely approved it or allowed it in any form, it's here to stay. So how do we best take care of these patients and not necessarily even scare them from the medical field, right? Because if we are making these patients scared, they're not even going to come see us in the hospital. We're not going to be able to take care of them, which is why we all got into this career, right? To help care for our patients. And so my biggest thing and like one of the biggest takeaways that I've had during this time is we just got to destigmatize it because there are ways around it. So I just want to go back to like the tacro example real quick, if that's okay with you all.
Yeah, absolutely.
But so like for the tacro, for example, we talked about CYP3A4 and how the CBD component of marijuana inhibits that enzyme. And so tacrolimus is metabolized by that, which in result will increase our amount of tacrolimus in the serum and could increase our risk of side effects of the tacrolimus. So now you have an increased tacro level, which is, when you think about it, more immunosuppression. Woohoo! But all drugs come with side effects. And so by increasing that, we're seeing that the side effects are increased. So nephrotoxicity, our neurotoxicity, potentially even hypertension can develop. And so the studies that have been published around the tacrolimus levels really show that if you consume CBD and you stay on that same level of tacrolimus, that tacrose level is just going to jump and be out of range. And like I was talking earlier, you convince a patient, and then all of a sudden the patient doesn't have a supply of their CBD. Now your tacro level has gone lower, but you've already adjusted their tacro to be a lower dose. So now they're subtherapeutic and increasing their risk of potential immunocompromise because they don't have a proper immunosuppression on board. And what's really important is that we understand that although you've adjusted the medication, you also need to readjust for a patient that may stop taking CBD. It's like that same warfarin case. If they come into the hospital and you start them on that same amount of tacro that they were taking outpatient, their levels are not going to be accurate because they're not having that same suppression by the cannabis.
It is absolutely wild to me, and I love the whole, cytochromones or 3A, 4, and 5 that we were talking about, and then like the peak glycoproteins and how it will inhibit, the drugs being removed because of the cannabis, and like it's just so mind-blowing and cool to me. And so I want to touch back a little bit on the point of neurotoxicity. And I, coming from a SICU, I took care of a lot of liver transplants, and so we would see the neurotoxicity in our patients who weren't telling us the truth about their cannabis use. But how do we differentiate when we are thinking neurotoxicity to actual marijuana-induced psychosis?
Yeah. I think that that's like our biggest challenge, right, as practitioners is figuring out like what is what and what is the difference. So I think process of elimination sometimes is what's going to have to play in here, right? Because our patients aren't going to always tell us that they're on
No,
cannabis.
they're not.
If their urine tox doesn't pull it up because they're like, oh, I'm going to the hospital in 3 days. In reality, the cannabis can't stay in your system that long, but the urine tox may not pick it up. And so it's really going back to those traditional, what is the neurotoxicity and what other things do they have going on that could affect neurotoxicity? If we're looking at neurotoxicity solely from a tacrolimus level, the first thing as a bedside nurse is, hey, I have concern for neurotoxicity in my patient. Can we please get a tacro level? You are the bedside nurse. You know the subjective level of your patient. You saw what they looked like at 8 a.m. You know what they look like at 2 p.m. You'll know what the difference is. And so it's highly important for you to advocate for a redraw of lab levels for the tacro, especially. Most tacro is done twice a day, which means we could get twice a day labs if we needed to because of the peak and trough that we have available to us. So that would be my advice. Like if you really think that cannabis has to do with it, then to take your knowledge as a bedside nurse, eliminate everything else that could be causing neurotoxicity. Are they having, other medications with neurotoxic factors? Do they have like a neuro side of them? Did they have like a neuro procedure? Or are they having like hypertension, hypotension, something like that that could be contributing? Because in reality, the hypertension, hypotension doesn't really come with the cannabis. We don't see that as much. And so if you're seeing that kind of thing, then maybe walk that route.
Those are all really great points. So Megan, you talk about this neurotoxicity and, making sure that we're, looking at all these signs and symptoms, which is such great advice. But how do we truly know if it's induced psychosis?
Yeah, so one of the side effects of a consistent use of cannabis. So a lot of the studies are more with consistent use of cannabis over multiple days to weeks, whereas if they have like a one-time thing, it may not necessarily be induced psychosis. But in these patients, their behaviors are almost a 180 from what they traditionally would see, is that they their family says when they come in, for example, you're doing a family interview because they're intubated, right? And the family's like, oh yeah, normally they're very rational. They work with us. They go on walks every day. They go to this group and have a meeting every day. But now they don't want to interact with anybody else. They are very violent with us. Or for example, you're asking and interviewing because you guys have had to intubate them and sedate them due to their violence and their agitation levels. That is something that, with a history of cannabis, seeing that more 180 flip where they have this change where they're maybe agitated or violent or potentially disengaged, that's really where we see more of the cannabis-induced psychosis side of things, is that change in their, not necessarily a gradual change, but really it goes through like a 180 step where they're like very different from baseline. And when I think and I kind of compare it to is like somebody who may have dementia, where occasionally they get a little agitated. But in our psychosis induced by cannabis patients, it's really more consistent all the time after a consistently long use of cannabis.
And thinking of the people who are using long-term cannabis,
Yeah.
we're going to see that a ton in our outpatient setting, especially for those patients who are using it for that nausea, vomiting, um, symptoms. But you mentioned earlier that sometimes even using marijuana can cause more nausea, vomiting, or as we would call it, hyperemesis in the hospital system. So what do we do when they're presenting with hyperemesis? What do we do?
Yeah, so when you think about like a patient that comes in with hyperemesis syndrome, really with them, it's thinking about rule out of other things is like what most people are thinking, right? You're like, oh, do they have like a gallbladder issue? Do they have GERD? Do they have this? Do they have that? Right? You're trying to figure out all of this. Cannabis, for the most part, is not our first thought. But patients who may be using it for nausea could go overboard and just use a little too much, where it converts into this hyperemesis state. And with these hyperemesis patients, some of them get to the point where they can't eat at all. If they eat, they vomit. But they have, for the longest time, thought if I eat this, then it's if I take my cannabis, I'm gonna eat. Well, now it's a negative effect for them, but for the longest time, it still worked for them. So they're like, I'm gonna keep doing it. So they come in, they're vomiting all the time, they're not able to keep anything down. All of their workup is negative. That's where you're like, well, have you used cannabis recently? Have you taken marijuana? Was there Utah's positive for that? So looking at that, but then from the nursing, the bedside, are we properly rehydrating them? Because as a result of all this hyperemesis, they are becoming dehydrated, and that's affecting now multiple other organs. Not only is the cannabis affecting organs, but now you have their dehydration, their lack of fluid, their potential blood pressure changes, and all of that is a tier down the road to other complications.
Gosh, and then it leads into so much more, because you think about dehydration and you think about not eating, and then you think about what is their glucose doing and what is this doing, and like, gosh, there's so much for us to learn that we thought we knew about marijuana and cannabis use that really we are just barely scratching the surface.
Yeah. And when you think about it, it's like dehydration. They're not eating. Now you're putting them on two feeds. Oh, they might end up with like an ileus or something because they haven't been eating. But then you're like, well, now I have to put them on a TPN. And then you're now working at a whole new titration off. I got to get them off a TPN. I got to get them back on two feeds or I have to feed them. You've just extended their hospital stay. But when in reality, it's we need to get down that cannabis, start with soft foods to help them slowly get back into that routine of eating. And so it's really important to take that time to get the history, look at all the factors, but rather not. I feel like the first thing when we hear hyperemesis, when we come in, it's like CT, is there anything wrong internally? Do they have GERD? Throw some pantoprazole at them and hope it works. That kind of thing. But reality is that we got to look at it from a whole picture and see that we need to hydrate them to help them feel better, to help them stop with this vomiting that they're cyclically vomiting.
As Sarah mentioned, like I think like we're just scratching the surface of cannabis use. And you had mentioned before, like we don't have a lot of research on it and it's not going anywhere. So like from your perspective, what do you think the future of cannabis use in the hospitals might be? And do you think that it's different? I mean, I know you did your work in Texas prior and now you're in Washington, correct? Like, do you
Yeah,
think it'd be different in the different states that you're in and what the future will look like?
I absolutely think that cannabis and how we see it is different from state to state. I was in Missouri prior to going to Texas, which was even more conservative than Texas was, and now I am in Washington, it is fully legal technically in Washington.
It's
And
quite the
so
swing.
everyone
Missouri to
can use it.
Washington.
Yes. And so for me, when I think about, what do I want to see with this, like my first step is destigmatizing it. And it's going to be a hard task for all of us. Um, because we're so used to it being in the fact that like it is a bad thing. It's almost in the same category as like street fentanyl and things like that. But the reality of it is we're seeing it make a comeback and seeing it become a thing of use in our chronic pain, in our cancer patients, and things like that. I think that hospitals are going to have a very difficult time in the legalization and the legalities of it. But it's also really important that if patients are chronically on it, that we're aware of it so that we can adjust medications properly, because that's my whole job as a pharmacist, is to adjust medications, and that's your whole job as a bedside nurse, is to see all these labs come back, and when they start coming back weird, what is affecting that, and why is this weird from what they were doing outpatient. And so until we see further movement in the legalization and things like that, or even potentially the development of an FDA-approved product for some of these chronic pain syndromes or chemo-induced nausea and vomiting and things like that, where we do see very good data for its use, we won't be able to adequately treat all of these patients inpatient. But what we will be able to do is adjust their medications according to their use. And I think that's the first step for us.
That's super amazing. So if what I'm hearing here is the key take home is we got to destigmatize it for sure. Definitely build trust with our patients, make sure that if they're taking it, we're not here to tell you that it's bad. We're just here to tell you it affects other things that you might not be aware of, and that the more transparency, the better we can to, treat you. Are there any other one or two key take home messages about that you would want a direct care nurse to know about their work?
I think for me, when I think about what can a direct care nurse do in the cannabis realm, really comes down to become the patient advocate and become the patient's friend. Because from the medical side and from the pharmacy side, we don't have that opportunity to create that relationship. And so for me, it's a matter of you create that environment of safety with your patient, but then you also get that opportunity to help monitor these patients. Are they having weird respiratory symptoms? Has their blood pressure all of a sudden changed and we don't know why? Have their drug levels that you're seeing come back in the morning been weird? Are their GI symptoms changing? But really thinking about their whole body, and more than just the lungs for inhalation or the GI for oral, but realizing that those CB1 and those CB2 receptors are across the entire body and can be affected by the whole body.
One of the things we don't even touch on is the use of vaping with CBD and THC and how that could be brought into the hospital, which could be impacting all of these different labs.
Isn't there a bunch of fungus among us from the vapors?
Yes, so many fungus among us. And, so I think we could have a whole nother conversation on this. You have been absolutely stunning as a guest, and we are so grateful for your insights. I thought I knew a lot about cannabis, and I'm learning that I absolutely know nothing, because we know cannabis, it's a substance that so many people are using, as Brandy just said. And as you have said throughout your talk, we've got to just destigmatize this, especially for our nurses in critical care. And this just leads to more education that we need to create at AACN, helping. You can help us figure out what are the questions that we need to ask, what are the answers that we're looking for, and then how to advocate for that safe care. So, to our listeners, we hope today's conversation gives you practical takeaways and can bring your practice to the bedside and to your patients. We are so incredibly grateful for you, Meagan.
Well, I thank you all for having me. This has been a pleasure for me to get to kind of share this and bring awareness to the fact that it may have some good in it, but it does come with some risks.
Thank you again, Meagan. This has been great. We want to thank you to all of our listeners for joining us today. We would love your feedback on this episode and any ideas for future episodes. Please send that feedback to podcast@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning quarterly journal, AACN's Advanced Critical Care, with information available at www.aacn.org/advancedcc.